Good morning. As we turn to solutions, healthcare is a very appropriate place to start. It is a solutions-rich environment, and I'm glad to present a terrific panel to you this morning. The panel's bios are in your books, so we're going to dive right into it. One of the challenges we face in healthcare that everyone understands well are the rising costs and the fact that costs in healthcare outstrip the ability to collect tax revenues to pay for it, outstrip corporate earnings, outstrip family budgets. So we're very much in need in finding strategies to control healthcare costs that are consistent with gaining popular public support or even patient enthusiasm for those strategies. And I'd like the panelists first to comment on where do we find that game plan, strategies to control costs that reach applause. Kavita, can I ask you to start?
Start with the easy question. Yeah. Yes, of course. So one frame that I always use to think about healthcare in general is from someone that I kind of grew up admiring, Richard Feynman, the physicist, and what I cannot build, I cannot understand. And so we fundamentally have that issue with healthcare systems. And I think the movement from healthcare as a cottage industry to an organized system is where we find the opportunities that you talked about, Lois. And then specifically, I think we also have to reevaluate the science of how we're looking at healthcare. And traditionally, medicine, which has been equated with healthcare, has been really an extension of biology and the life sciences. And so how we can now think about taking lessons from physics, complex adaptive systems, knowledge turns, kind of even higher data processing. As we talk about collecting all this data, knowing what to do with it and how we use it has become incredibly important, but is not a field that medicine has traditionally been very rich in. So can we do things in machine learning? And I'm sure Sasha will touch on kind of the health IT, but it's more than that. So the opportunities for the cost and the savings come from that. And I'll say that kind of on a more, I love the idea at New America of putting out kind of a provocative way of thinking and new ideas. In order to get at kind of the patient-centeredness, we must interact not just between our individual silos of healthcare, primary care, specialty care, nursing, dentistry, et cetera, but also really have an intermingled relationship with social determinants like education and communities of design and living. And we didn't like to use the word poverty yesterday, but I talk about kind of movement from poverty. And so that is fundamentally a lot of what healthcare and our promises in driving down cost, but also raising the value of healthcare come from.
Sasha?
Sure. Well, strangely enough, paradoxically perhaps, I think the solution for a lot of healthcare's ills is not to invest in any one particular solution. And by that I mean, like, we should be looking at healthcare as a platform that needs to be extensible, that needs to have portability of information, that needs to have interoperability of devices. And the only way you get to that is to be thinking of these things in terms of what are we going to build that's going to last for our entire life. Right? The second you're born, you get a medical record, and then you keep it for the next 76-odd years. And right now, most of healthcare is all about building, as Kavita mentions, these silos. You're the CAT scanner folks, and you want that to interoperate with your X-ray machine and nothing else. And you want, to own a hospital, and you want to create places where you can control the flow of information for patient data. Well, if you look at how we think about roads or electrical grids or et cetera, we think about them in terms of a platform that has to last for generations. And the only way you do that is to open it up. The only way you do that is to have open standards, interoperability, extensibility built into the very foundation of the healthcare system.
Atul.
I think the best way yesterday's discussion about debt and economics of overall give us a good framework for thinking about this. The economists wanted to suggest that our only way to think about healthcare costs was to raise Medicare age and sort of treat it like the productivity problem that the productivity of other sectors of the economy just can't find a way into healthcare, and so we just have to figure out ways to cut. The reality is that we're dead if we don't bring the productivity revolution to healthcare. I think there's a way to understand it. there's a bell curve. We now have data showing what the best results are for care, whether it's for coronary artery bypass or pneumonia or asthma or whatever. The best results, the people at the top of the bell curve, are not the most expensive people in the system. In fact, they're often the lowest cost people in the system. And I think I can give you a test of whether we are making healthcare reform actually work by pointing out to you a project that was at Children's Hospital Boston, where they said, let's make great asthma care. And what they designed was a checklist. God knows why. I never thought I was going to write about checklists as my major thing in life. But they said they found half a dozen things that if you did them right could make great asthma care. Only one of them was paid for by insurance, and that was making sure a child got an inhaler, a controller inhaler. The rest of them were things like make sure there's a phone call a month after. So take a child who's been admitted to the hospital with asthma, make sure there's a phone call a month later to make sure the kid is getting their inhaler and the parents know how to give them the inhaler, have a home visit, make sure they don't have a mold infestation or dust in their house, and ask if the family actually has a vacuum cleaner. It turned out a quarter of the families in Boston don't have vacuum cleaners, and so they prescribed a vacuum cleaner, gave it for free because it was cheaper than even the inhalers. The combination lowered their healthcare, their admissions to the emergency room and to the hospital for asthma by 80%. Now, that gives us the picture of what you want healthcare to be like. Why hasn't that happened? Well, there's a couple of things that then we want to look for. One is the recognition that guess what the number one source of revenue for Children's Hospital is? It's asthma admissions. And this project was going to threaten to bankrupt it. So what you need are three things that are actually in reform, but implementation will determine whether they succeed or don't. Number one is you need data to point communities toward what their higher cost areas are. Is it to be working on asthma? Is it to be working on the explosion in home nursing costs? Is it to make sure people are not going to the emergency room or readmissions to the hospital? What is the value that you need to be working on in your local community? Second is care redesign. Once you know your problem is asthma and cardiac prevention and how your ICU costs are running, you need to design the checklists that get the teams on the right focus and get them working together. And then third, because the teams don't actually work together on these problems, to make that great asthma care is a complete contradiction with the way we're paid. You need to redesign the payment system. We will not have a national solution that will be a generic answer for all this. It will mean going to McAllen, Texas, or going to Washington, D.C., or going to Boston and saying, what is the map of our problems? Are we going to have the doctors, insurers, public and private, hospitals, and employers and general community working and pushing in the same direction? And so I think that the first place is taking advantage of the pilot programs and reform in ways that are not about killing them off, but actually making them successful. And so a great deal will unfold in the next year about whether we take advantage.
So, Atul, in taking these innovations and bringing them to scale across the system, what do you see as the key leverage points for gaining momentum?
We're going to try one next week. We're coming back here to D.C. first for a private meeting of 15 communities that we're trying to sign up to say, do you have the medical leadership and non-medical leadership to sit together and begin to ask? So, for example, one of them we're trying to talk into is Buffalo, where there are a few medical leaders willing to say, we're going to, in the next 5 years, keep healthcare costs in Buffalo under inflation and measurably raise the quality of care. But you need the platform. So they need to be able to get together in ways that they have a place to talk to competitors, competing hospitals, competing medical groups, get insurers who have the data about where the big costs are and begin to start working together in that way. So if I had to say, what is the next sort of most critical step, ironically, it almost has to do with appointments. Don Berwick has been nominated to be head of CMS. He head of Medicare. He is one of the few in the country that kind of understand these pieces and has credibility among clinicians and the insurance side for actually working at these problems. And sort of the subterranean story is that his nomination may never come to light because the treatment of the nomination process has been turned into like what people are trying to do to Elena Kagan in the subterranean, the blogosphere. He's been viciously attacked as socialist, communist, rationer, and now may never bring that nomination up. So you need to get people on the ground who can implement and start it going. And if you stall that implementation, it won't even start to create that platform for bringing communities together on this.
Yeah. Sasha, information technology in so many other fields has been a point of leverage. It hasn't achieved that goal in healthcare in the same way. Can it?
Can it? Sure.
Will it?
Will it? That's the real problem. It's interesting. If you look at just about any other industry, if it were so completely non-competitive and, top-heavy and producing such a flawed product as the outcome, would have been killed off a long time ago, hopefully. And when we look internationally, we know that we're paying more and getting worse service in the United States than a growing list of other industrialized nations all around the globe. And I think, it's indicative of a captured market in a way that is seen in very few other market sectors. It's incredible to me how completely non-intuitive our healthcare system is, and how every single time I go in to see a doctor, I have to fill out the same forms and provide the same information and go over the same stuff, and yet they still don't have access to my history of information, my actual healthcare files. It is, in my mind, a problem that is more psychological and more political than technological. The technical solutions are, if not already out there, very close to completed and available. And so when I talk with, I've been talking a bit with like Red Hat about sort of how do we incent people to implement better solutions, and we constantly come up against the same problems, which is like the path dependencies that have been created by a completely dysfunctional market are so great that there's this like huge barrier that one has to overcome to implement solutions that just about everyone agrees like that would be better if we could get there.
Can I, something on IT though that puts it down to kind of concrete tax. The University of Colorado, like many academic systems, because of investments in this stimulus that the president did at the beginning of last year, put down $65 million for Epic, which is a very commonly used platform in healthcare. I met with a CIO at the University of Colorado in Denver, a brilliant person. They have an entire floor dedicated to administrative staff to implement and kind of pilot Epic. I said, how many staff do you have dedicated to understanding how to re-engineer kind of the systems of how we use this to deliver healthcare? And they had none. And I said, well, why is that? Why not invest in somebody who actually understands the healthcare world and the biology and psychology as well as the technical pieces? And they said, well, we've already spent $65 million on Epic. We can't spend more on what we think the staff should be able to understand and do on their own. And so I think there's also kind of so I'm one who does not believe that health IT in and of itself is going to save us and reduce our cost, but it is a necessary tool in one of the many things that when a tool talks about checklists is just a basic necessity to get to that point. But if we don't make that extra smaller margin of investment, we won't see the return on that investment.
So you're talking about investment in the underlying kind of human system.
Kind of the health, right, this more complicated
to realize the benefits
system
of IT and to get more leverage around it.
And as well as the data. I mean, one thing that always kind of is astonishing to me is that we bank, whether it's personal health records or complex health systems, the amount of data that's actually utilized, even in clinical decision making, is a fraction of the available data. So when people yesterday talked about better measurement of outcomes, we have that data. We just aren't, the science of using that is not something that medicine has really embraced. And that's where we need to kind of, change the way we look at the science of healthcare.
Yeah, a good friend of mine, just to concretize this even more, like a good friend of mine just opened up a micro practice out in Oregon, and she had the benefit of building something from the ground up. And she asked me, so what's out there? I'm like, well, what do you want to do? And she wanted to do electronic medical records, which already puts her into sort of the elite of, let's start without the paper conundrum that so many places are suffering under. And for electronic medical records, just for one doctor doing a micro practice, you can pay $25,000 for a system, or you can get it for free. And now they're not functionally equivalent, but they're very close to it. But you can imagine, like, if there's that kind of discrepancy, if you were told, like, hey, you can buy this car and it'll cost you $1 or $1 million, that would be kind of where we're at right now with a lot of these technologies in medical care.
So will the breakthrough come from the medical community or healthcare itself? Or is this one of these cases where the breakthrough needs to come from outside healthcare and then be taken advantage by healthcare? What do you think?
Well, the fascinating thing is that every time we've changed incentives, that people react incredibly quickly.
Yeah.
And so on some basic level, the question is, how do you redesign the incentive for a community of clinicians? We have 1 million doctors and 2.5 million nurses, and none of them are focused on the question of how to make care higher quality and lower cost. Mm-hmm. They're just interested in how do I make sure that we have our revenues that we have to follow through on. So designing now there's no off-the-shelf payment system either. We brought 10 communities together last year that had the lowest third of Medicare costs but the highest third of Medicare measured quality. And the pattern of them was that nearly all of them had changed their clinician payment structures. But the other pattern was they were all very different. 6 of them had moved their physicians to salary models. 4 of them continued to pay them on a fee-for-service basis but built in bonuses. And they had to have a history of how they built them in. If you announce we're going to make our system so that every physician in America is on a salary, number one, it would be a revolution. But number two, you have every chance it could look like the VA in the 1970s when docs on salaries went home at 3 o'clock in the afternoon and didn't become the kind of high-performance machine that it became in the last decade. So the short answer is that working on payment redesign at a community level, finding just, my goal would be in the next 3-4 years, find just one community does what has not historically been done, change their payment system in a way that costs actually go down and quality goes up. And once we have that one community, it will become something we can replicate.
Do you need IT for that, or is it more about real leadership?
I don't think it starts with IT, but every community, so that in those 10 communities, another thing they had in common was virtually all of them had turned to IT to put it into their community doctors' offices. Because once you start to have a community that is working on improving quality and lowering cost, you start finding you need IT to get there. Now, none of these communities have, they're growing less fast than the rest of the country. So instead of triple the inflation rate, it's double the inflation rate. It's still not quite, where we need to be able to live within our economic constraints.
Sasha, is this going to come inside healthcare, or is it really got to come from outside?
In some ways, we're waiting for a lot of the folks to just die off. It's sad, but it's, a lot of these transitions happen generationally. When we think, like, what's healthcare going to look like in 2050, nobody's thinking, like, oh, we're going to have these stockpiles of paper everywhere. But it's such a slow process. And again, it comes back to these path dependencies that have been created over decades here in the United States. And it's part of a mindset where we treat in the United States symptoms, right? We're not talking about preventative care here in the U.S. We're talking about, like, you go in to see the doctor once you've actually gotten sick, once you have an acute illness, once you've been hit by a car, what have you. And I can think of nothing that sort of drives that home more than the way in which we pay for our health care. Like, imagine a subscription model. It's like you pay $100 a month and you get all-you-can-eat health care. That would radically change the way hospitals and doctors treated their patients. Because their goal then would be, how do I keep them healthy? As opposed to, how do I treat them and charge them for every which, test and what have you that I can possibly run on them. And we don't think that way in the United States. And we don't think of health IT as, how do we create systems that keep people healthy? We create systems that allow us to run more checks and balances and more tests and more procedures. And I don't know how you get there given the mentality that we have today in the healthcare industry.
Sasha, how do we get there? How do we?
How do we get there?
Sorry, Kavita, I meant it. Kavita, how do we get
So
there?
I'm a little more rosy, and since this is about solutions, I'm not waiting for people to die off. I'm kind of hoping that,
especially on a healthcare panel, right?
Yeah. I'm a doctor. I'm supposed to keep people alive, but that's also a problem. I'll say that one fact that'll preface this. The growth in spending, a lot of studies have shown that the growth in spending isn't just kind of the ICU care in the last 6 months. There's a burgeoning in the outpatient setting as well, which is driving a lot of the cost of healthcare up. And when, on average, I would see in a busy day 34 patients in one day and spent face-to-face time probably 2 to 3 minutes per person, and then 5 to 7 minutes. And this has been reproduced in various studies dealing with various administrative paperwork and things that were not something that an MD needed to deal with. I do think that there are solutions to make our practice more efficient. And instead of kind of interplaying the word hospital and what we do in all of our healthcare, I'm really hoping that kind of this concept of a patient-centered and a primary care-focused practice, which needs to be paid for, which gets at the financial incentives, because once we start to pay for it, which we're starting to do with the health reform bill, but only starting to do, once we pay for that, then we will have this kind of drive, this change in behavior that, honestly, if you look at most medical students and nursing students when they come in, that's ultimately what they thought healthcare was and should be. So I do think it will be to align the financial incentives, and that'll come from within and outside of the healthcare community.
You know, to a part of what I've enjoyed about your writing, it really builds off of what Kavita was saying, because in your writing you are able to take these systemic issues, but in so many of your pieces, and relate it to the complexity and the reality of patient care, and the challenge of being a practitioner and of making mistakes and of getting things right. How does this, how would an improved system look for the patient, for the individual practitioner? How do you visualize that?
The thing I keep coming back to, which Kavita touched on, is this idea that we've come through this century of incredible scientific discovery. And what I'm encountering, not just in the US, but also middle income and poor countries where we've been doing work, is there is incredible desperation on the patient level to make sure I have access to that stuff. Yeah. The century of incredible discovery, and I just want to make sure I get the optimal sort of way of doing it. But the trouble is that what we've discovered is we've enumerated 13,600 individual possible diagnoses that can hit you, 13,600 ways your body can fail. We've generated 6,000 and growing drugs that can be prescribed for those. And we have 4,500 medical and surgical procedures we've designed to help along the way. And the job of every community of medical people is to deliver on those 13,600 different service lines. There is no industry that's ever been designed that has to deliver on 13,600 service lines in every community in the world, customized to the individual's needs. That's what we're trying to invent. So, you know, taking into account that this is our ambition, it's a fantastic thing. It's this amazing ambition that we've taken on. So for a community like I grew up in rural Ohio, a town of 20,000, Athens, Ohio, has about, that's what I can envision. You have about 40 docs in town. They have to make sure that any of those 13,600 things that walk in their front door get taken care of. Now, for a bunch of them, you just send it to Columbus. Okay. But they probably take care of 8,000 of those 13,600 things, and then they have to figure out how to do it well. And if you look at their pneumonia care, it may be great, and then their heart attack care may be lousy. But managing variety and dealing with this component set of systems and having, can we get them to the subscription model? They don't even talk to each other. These 40 docs in town, they don't have the computer systems speaking to one another. Sure. They don't have any. So to get them to that point is to think about, on that very, very nuts and bolts level, what's the next best step that it becomes a delivery system for 13,600 service lines. Like, at the moment we do most of them weakly and unreliably and very, very expensively. So we want to start working our way down the list of lines and zero in. What are the first 10 we're going to work on and improve and get some real mileage out of?
Fascinating. Let me open it up to your questions.
Hi, Neil Baer. How do you think about major public health issues in terms of the checklist or IT, like obesity, alcohol abuse, and smoking, that cost us billions of dollars that if people didn't do it, we wouldn't have those problems? What new ways can you, or new approaches can you apply to these problems?
Who wants to respond?
Well, to me, what's fascinating is I think it sounds like 13,600 is going to be the take-home.
They have to make sure that any of those 13,600 things that walk in their front door get taken care of. Now, for a bunch of them, you just send it to Columbus. Okay. But they probably take care of 8,000 of those 13,600 things, and then they have to figure out how to do it well. And if you look at their pneumonia care, it may be great, and then their heart attack care may be lousy. But managing variety and dealing with this component set of systems and having, so, can we get them to the subscription model? They don't even talk to each other. These 40 docs in town, they don't have the computer systems speaking to one another. Sure. They don't have any, so to get them to that point is to think about, on that very, very nuts and bolts level, what's the next best step that it becomes a delivery system for 13,600 service lines. Like, at the moment we do most of them weakly and unreliably and very, very expensively. So we want to start working our way down the list of lines and zero in. What are the first 10 we're going to work on and improve and get some real mileage out of?
Fascinating. Let me open it up to your questions.
Hi, Neil Baer. How do you think about major public health issues in terms of the checklist or IT, like obesity, alcohol abuse, and smoking, that cost us billions of dollars that if people didn't do it, we wouldn't have those problems? What new ways can you, or new approaches can you apply to these problems?
Who wants to respond?
Well, to me, what's fascinating is I think, it sounds like 13,600 is going to be the take-home number from this panel, but that's a really known list, right? It's not like we don't know what those are. And, well, two things, actually. One is I think it's relatively easy to design kind of an actuarial element to a lot of healthcare that we don't use. And you can look no further. This exists. You go to WebMD and you can put in your symptomology and it'll pop up some stuff, and that's helpful. Now, as we know, the human component, we like to think of healthcare as it's a science. And it's also, but the reality is it's kind of like an art form. And we don't appreciate that. And we certainly don't appreciate that with preventative disease care and all this stuff. So when coming back to like obesity and smoking, et cetera, like the things that kill us in terms of the cost and et cetera, are the liability, are the preventative diseases, are all these things that, were we focused on something entirely differently? Were we focused on how do we empower us, the people, to take ownership over our own healthcare outcomes and have control over our information, like what goes into the healthcare system? If we did that, we would have a radically different way in which that we approach healthcare, in which we approach the relationship between doctors and patients. It wouldn't be that you get 3 to 5 minutes with your doctor, or if you're lucky, you get 10 minutes or 20 minutes with your doctor. That's if you're lucky. We would be thinking in terms of long-term relationships and community building.
Let me try diving into this, because I think the obesity and smoking are two really interesting examples because they're completely different. Smoking, they're both behavioral problems. Smoking, we've actually discovered the checklist of things that can make it more likely a patient will quit smoking. We've discovered that a physician that offers to give a prescription to their nicotine patch or other things, and there are certain kinds of smoking cessation programs. And the reality is we don't deliver on them. You take a patient with smoking, the single most important thing a primary care physician can do is work on their smoking problem, and we can make that checklist and try to get it in place and make it work. It's a problem of what I'd call ineptitude, failure to deliver on existing knowledge. Obesity is completely different. It's another behavioral problem. We have no idea how to change eating behavior in ways that keep people's weight off for 10 years, which is a length of time you need to gain the benefit over your healthy lifetime. The only solution we have is that for the extremely obese, we can do radical surgery, and that's the one thing we got. For any kind of diet we have, people will lose weight for a year. About 2/3 will lose weight for a year. By 5 years, only 5% will. So there, it's going to be scientific discovery. It's the NIH. It is research to find what could be the potential checklist of things that we could work on. And so I don't want us to forget the discovery of new science. It may be a pill in the future that can damp down what is a evolutionarily driven urge to eat. Or it may be that we can find those behavioral components like smoking that can get us weaned off of it, and that, things like taxes and other things on sugared drinks may work, may not work, but we need that testing and piloting. So I think they're contrasting in how we have what ways we have a shot at solving them.
Let's finish up with a lightning round of questions. So Philip, you want to go next?
Hi, I'm Phil Longman, New America Foundation. There was a study came out recently from RAND, published in Health Affairs, that really startled me when I saw it. It looked at the disability rates of population 50 to 64. And for the first time, or I should say as long as we've had any kind of data on that subject, it shows morbidity going up to the point that 40% self-described as having one problem with daily activity, such as walking 10 steps on a stair without being winded or standing for 2 hours. So we heard a lot of talk last night and yesterday about, we could just raise the retirement age, right? And there's this kind of general expectations about baby boomers that you're all going to live longer, so you should probably work longer a little bit too. But it looks like to me we're actually at a inflection point where morbidity at late middle age is already increasing. We've got life expectancy in large subpopulations in the United States actually starting to turn down. And we know that a lot of this has to do with environmental and behavioral factors. So in light of that new reality into which we're now planning, I just wonder if the panel could give their thoughts about what kind of a delivery system platform could be designed to take account of that changing reality.
Okay, question behind.
Joel Garrow, New America in Arizona State. How soon do you see the end of the disease model and the death of hospitals? I'm thinking of cheap microfluidic arrays that track our metabolisms daily and alert us months and years in advance to something going wrong, so we don't have to wait for symptoms to appear and then respond late, heroically, and expensively.
Hi, Leif Hazy. What gives you confidence that the numerous pilots and demonstration programs, the promising ones in federal reform, will work given the checkered history of such pilots in the past?
Two other questions. Okay.
Yes, hi, Lou Viana. What proportion of tests and procedures that are being administered are considered essential, and what proportion do you think are being done in the abundance, in the interest of abundance of caution?
Justine?
I'd like to see us start, knowing that you have to start with where we are in one sense, but I'd like to see us start with the goal of maximum wellness and functionality. And that opens it up to what the patients do and what the medical services do. When they ask about prevention, and CBO looked at it in the healthcare context and said, oh, that costs money. It doesn't save money, because they looked at the testing for early identification of illness with no follow-up. I would like to see them look, for example, at what people are doing in functional medicine, which says, what is the biochemistry of a well cardiovascular system, a well immune system, and so forth? How can you more scientifically, not just alternative lifestyles, but more scientifically. Keep your chemistry as strong as it can be.
Okay.
Can we look?
One more question from Mina, and then you're gonna have 15 seconds to respond. So.
Yeah, but I'd like, for example, to look at the data we have from that perspective, and I'm invited to a conference in June on the data, etc. I'd like to see us get the new doctors oriented a little bit to that.
Thank you very much. Mina?
I was wondering whether there's any attempt to take government institutions like the VA or the military, because you've got a control group there, and institute all these reforms that you're talking about that need to be done.
All right. Lightning rod answer. Sasha, begin.
Sure. Well, let me start by saying, well, start and end by saying, health IT is a tool, it's not the goal. And as such, in my mind, what the real question is can we get not just the lawyers and the doctors talking, but some technologists in the room as well, to be talking about the efficiencies that are possible and the better patient outcomes that are possible, right? Maximizing wellness, living healthier lives longer. Like, these are the outcomes that we want, and Health IT can help with that.
Kavita?
All right. VA and military, yes, and we're already trying to use some of the lessons learned, and we need to do more to extend that as well. There are a number of proprietary forces that try to fight using that, as well as cultural issues, which also gets me to the behavioral issues in defensive medicine. And there is a very large proportion of costs that are driven by that, as well as the need to be prescribing and giving. And it's far easier for me to write for an MRI than to spend 25 minutes to discuss with you why you probably don't need it. And the death of hospitals will come when we no longer reward the hospital financially for keeping people there, as well as for being admitted over and over again as a point of entry for payment on insurance.
She made my job easier. I only have to take a couple of these. One thing that's in common about the idea of wellness is that Don Berwick has called it the triple aim, that we should aim to demonstrably lower costs, improve the quality of the care, and improve the health of a community. And we need metrics at a community level that have all three. Combine the look at smoking and obesity with the look at what the costs are in the system and what the medical components of it are, whether it's safe and of high quality. And I think that's fundamental. I'm going to push back on the question of the reality of increasing disability. We do have, with obesity, some rise in disability, but on the whole, our degree of disability has declined enormously. We've added 5 years of life after the age of 65 since the advent of Medicare. People are far more productive much later in life and are much less likely to be disabled in their later years after 80. And one of our difficulties is that during this time, ironically, we went from an average retirement age in the mid-60s of 67 to a retirement age today of 61, and that's just not going to be viable, I don't think. But we do have that continued obesity trouble where there is this significant subpopulation of people who have weights of over 350, over 400 pounds who simply cannot navigate life as successfully, and they need a lot of help and science to understand what we can do better. And then the last thing about the pilots. The past history of trying out these kinds of programs and testing them is that you do find solutions and then Congress ignores it, no one ever universalizes it, goes nowhere. The challenge of now designing pilots to improve the payment system, number one is to get some that work. And then number two is to shine a light on them and make sure that they come into action. That's why I have been really delighted to get to join New America. There are a few functions that an organization like this can play. And one of them is to make sure the knowledge of where the problems are is recognized, but then also the knowledge of where the solutions are delivered. And the appearance and disappearance of pilots has largely been because there's been zero public pressure or knowledge of what has mattered.
And on that note, terrific panel. Thank you very much.